Alright, so the last part here is vascular aspects with pulmonary disorders. And the dominant thing to talk about is pulmonary embolism. So, let me see if I can grab the statistics out here for a second. And I know this gets right above. So what it says on top of the screen, I'm sorry, it says that venous thrombi detached from their sites of origin on blood vessel walls travel through. Okay, most pulmonary emboli come from the deep veins of the lower extremities, hence DVTs. And there's some data which I think is kind of startling. About 650,000 patients develop pulmonary thromboembolism annually, resulting in 250,000 hospitalizations. It occurs even in 60% of patients with DVTs, 60 to 80%, even though more than half of these patients are asymptomatic. 60% of patients who die in the hospital have experienced a pulmonary thromboembolism, and the diagnosis is missed in approximately 400,000 individuals in the United States every year. Okay? 650,000 patients develop it annually. It's missed in about 400,000 people a year. So that's why I wanted to set the stage with the statistics before we stop and look back at what's going on. So you try and look back at what the physical exam tells you, and about all of them have tachypnea, increased respiratory rate. More than half have rales. Half or so have an accentuated second heart sound. 40% or so have tachycardia. Some have fever. Some have diaphoresis. Some have an S3, S4 gallop. Some have signs and symptoms of thrombophlebitis, but only about 1/3. 25% or so have a bit lower extremity edema, 23% or so have a cardiac murmur, and 20% or so have overall cyanosis. So none of these add up to really anything significant, right? Because most of your patients with fever, you're going to go through pneumonia, etc. Diaphoresis is, who knows what that is. Developed rales, well, you're going to look through your pulmonary edema protocols, lower extremity edema. So there's nothing like the crushing substernal chest pressure. PE it just shows up in so many issues, has so many mimics, has such a wide variety of possible presentations. How many patients do you get in from a nursing home or from a long-term care facility who are tachypnic or maybe have tachypnea and fever? And most of the time you're going down the septic route when maybe we should be going through a PE route. So if we look at pulmonary thromboembolism, it's either a solid, a liquid, or a gas carried through the blood to a site away from its origin. And most of the time we're thinking that it's blood, or not thinking, we find that it's blood. Rare causes include a fat emboli. We're going to get fat emboli typically associated with fractures. The bone marrow pops out, goes into the bloodstream. Air emboli, which you see in scuba accidents, in IV drug abuse, in trauma, things like lacerated neck veins, stab wounds to the chest, etc. Amniotic fluid embolism you can get in your OB patients. Okay, by far the most common cause for a PE is a DVT, a deep vein thrombosis, the lower extremities. Sometimes the femoral veins, sometimes the pelvic veins. The risks for pulmonary embolism are the same for DVT. And you see the increased pressure, right? And seeing it's increased in edematous. So the physiological factors contributing to venous thrombosis, this is known as Virchow's triad, V-I-R-C-H-O-W, triad. So there's 3 factors contributing to venous thrombosis. Number 1 is venous stasis. Number 2 is endothelial cell injury, and number 3 is a hypercoagulable state. So venous stasis is things that you see in things like immobilization, your CNS patients, stroke patients, Lou Gehrig's disease, patients who just aren't moving a lot. They tend to coagulate, right? Again, why you see things like what's the proper term for that? I think it's coach syndrome or whatever, where you're flying for more than 10 hours or 12 hours in your cramped seat on your way to Queensland or Australia, and you throw a clot on 24-hour flights around the world, in Japan and Africa, all these long flights, and you're not moving, and you're having venous stasis. Same thing, status post musculoskeletal trauma, arthroscopic knee surgery. It's one of the reasons why you want to get people up and around. is venous stasis is obviously associated with an increase in thrombosis. B is endothelial cell injury. So from looking at cardiovascular, we know that a lot of us already have this underlying as an endothelial cell injury, but that's increased by things like cigarette smoking, by high blood pressure, by previously established cardiac disease, all those things. So when we look at the high correlation between cigarette smokers and pulmonary emboli, now that you know that nitric oxide is a vasodilator and healthy endothelial tissue secretes secretes TPA, which is the opposite of PAI. Some of this stuff hopefully is making more sense than just memorizing facts. You can sit there and go, well, why do cigarette smokers throw more clots? Well, cigarettes make you clot. Well, that's not necessarily an accurate sentence. You want to go back and underline what's going on with the cells. And hypercoagulable states, and the two most common hypercoagulable states we look at are cancer and pregnancy. Pregnancy simply increases the likelihood of coagulating. It's probably associated with estrogen changes and blood amounts of estrogen changing. Similarly, how oral contraceptive use increases the likelihood of a pulmonary embolism. And cancer patients are always at increased likelihood of both a DVT and a pulmonary embolism. So that's when you do your histories. So prolonged bed rest, trauma, surgery, gynecological cancer, etc. CHF, atrial fib, right? So with atrial fib, what you have is this constant sort of wriggling worm appearance of the atria. Instead of pumping blood into the ventricles, they're sort of and everyone knows the sort of pitter-patter normal pulse of atrial fib, which instead of lub-dub, or just a simple pulse is boom, 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 boom. Right, so it's all sorts of irregular. You get a lot of clotting going on inside the heart, popping in, and then the blood vessels go right off into the lungs, and very commonly as well up the carotids into the brain. Myocardial infarction and mural thrombus. Right, so we have clotting going on the inside of the cardiac walls, breaking off, going into the lungs. Spinal cord injury, again with venous stasis. Cancer patients being a highly coagulable state. Hormone replacement therapy, childbirth. So the pathophysiology of a pulmonary embolus is mechanical obstruction of the pulmonary circulation. Okay, so remember that we talked about for COPD, when part of a lung starts to shut down and not do a very good job, the lung shuts it off, and the lung says, okay, we're not going to send you any more oxygen. We're not going to send you any more blood. So you get vasoconstriction and bronchoconstriction. Right, so blood's not going to go to the area for gas exchange. And then hypoxia in that area leads to vasoconstriction. Vasoconstriction leads to bronchoconstriction. Okay. So you get some wasted ventilation. You get impaired gas exchange, hypoxemia. Okay. And if this goes on a regular basis, you can get pulmonary hypertension and right-sided heart failure. The same concepts that we went through in cor pulmonale. Right? If you have that bronchoconstricted, vasoconstricted area in the lungs, you're going to make the right ventricle work harder. The right ventricle working harder, it's not meant to work harder. It's probably going to dilate and give out way before the left ventricle. And a large embolus can cause an acute, second-to-second right-sided heart failure if it lodges in the pulmonary trunk. That's what we're looking over at here. That's what's called a saddle embolus. Okay. And that just completely shuts down coronary circulation, completely shut down the pulmonary trunk. There is no blood leaving the right ventricle going into the lungs. It's clogged up. That means there's no blood coming back from the lungs to go into the left atrium, which means there's no blood to go into the left ventricle, which means blood pressure is 0. So that just clogged everything up and caused complete and imminent cardiac failure. Okay, so clinical manifestation depends on the size of the embolus and location. It can be smaller, it can be massive, it can be moderate. Patients can complain of chest pain and dyspnea. Pleuritic means it's not going to be consistent, it's going to change with respiratory cycle. Tachypnea, dyspnea on exertion, maybe a fever, maybe having a productive cough. With a massive embolus, they'll have chest pains most commonly and deep shock. Low blood pressure because that blood's not going back to the left side of the heart, so they can't pump out blood that's not there. And you're going into right failure. If you're in right failure, you have distended neck veins and cyanosis. Oh, sorry, I'm just realizing that this is coming up a little bit to the side. So let me go back and have a larger view. The diagnosis, number one, you have to have clinical suspicion. You have to be looking at your patients and realizing this might be a pulmonary embolism, or else you're not going to go through with the rest of the tests. You should do a blood gas looking for low oxygenation and normal carbon dioxide. You could do lower limb compression ultrasound or venography. You could do a D-dimer, which has come out recently in the last couple of years to be a very preferable test to do, because there used to be no real blood test to do before you got to doing ventilation perfusion scans and Q scans and 16 slice lung CT scans, etc. So some facilities are going to say they'd rather a stat thin slice CT, which can be done pretty quickly in most centers these days, especially if they're larger. But the blood test, the D-dimer, they can be done by everybody. And the D-dimer just basically means that a clot has happened. So it gives evidence that clotting has gone on recently. And if it's elevated, and your patient's giving you the right signs and symptoms, a positive D-dimer is good enough to say that that's a positive PE. But in larger facilities, if you have a lot of backup, they're going to probably want to do either a pulmonary angiogram or a pulmonary CT.